Right. Okay. Not sure. I'm going to give a few minutes and then I would like to introduce us. Welcome to NAMI's Perinatal Mood and Anxiety Disorders. So, just going to give it a couple minutes here to see if people log on.
I'll talk to an empty room. That's fine.
Hi, Lisa. Okay, so we do have one panelist that has joined us.
Hello.
Hi, Jeannie. Thank you for joining us. We'll just give it a couple more minutes. Yes, it does look like it's going to be a great presentation. So Jeannie stated, this looks like a great presentation. I will just give it one more minute here, and then we will get.
I hope so.
Absolutely. How's everybody's day going today? Hi, Deb. Thank you very much for joining us. It's great to have you guys here. Annie, thank you for joining us. We'll give it a couple more minutes here. Okay, Lisa says, thank you for having us. Our heat has been being repaired, so it's a bit chilly, but otherwise good. I hope you get your heat repaired. That's definitely a necessity right now. But I'm glad that you're doing well. Giovanna, thank you for joining us. Natalie, thank you for joining us. Natalie, I cannot hear you. I don't believe that we'll be able to hear the panelists. So, but on the chat, if you guys have any questions, then I'll be keeping an eye on the chat and you just go ahead and send your questions there. So I think I'm going to go ahead and get started for us that are here. First of all, I want to introduce myself. My name is Laura Kane, and I am a board member of NAMI Northern Illinois. NAMI Northern Illinois is an active affiliate of the National Alliance on Mental Illness, which is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. What started as a small group of families gathered around a kitchen table is now the largest organization in the nation for mental health. Our mission at NAMI Northern Illinois is dedicated to improving lives of individuals and families living with mental illness through support, education, advocacy, and hope. What we do is we listen, we support those in need through various groups. So if you guys aren't aware, NAMI does offer a ton of support groups. If you just go to our website, naminorthernillinois.com, you can actually see the support groups that we offer, and they are free of charge to the community. So please go to the website and get those checked out. We also educate families and our community. We advocate by helping to shape public policy and programming for people with mental illness and their families. So today we have Amanda or Mandy Hahn. And thank you so much for being here and doing this for us today. Do you go by Mandy?
Usually Mandy, yeah.
Mandy, okay. So Mandy will be discussing postpartum depression and other perinatal mood and anxiety disorders, what they are, how to recognize them, how to prevent them, and what to do if you have one. Um, Mandy knew she was passionate about pregnancy from a young age. In high school, she would go to the library and check out all the books she could find about pregnancy. She graduated from Elmhurst College in 2009 with her bachelor's in nursing and minor in psychology. After working in labor and delivery as a nurse, she was quickly disappointed with the care she witnessed from some of the providers. She went back to school and graduated in 2012 from the University of Illinois at Chicago with a master's in nursing and began working as a certified nurse midwives in Rockford, Illinois. While working with high-risk, underserved population with a high incidence of perinatal mood and anxiety disorders, she became frustrated with the lack of accessible mental health care options available to her patients. She went back to school again at Frontier Nursing University, where she graduated in 2020 as a psychiatric mental health nurse practitioner, wanting to combine her passion for both midwifery and psychiatry. She received additional training and certification in perinatal mental health. So Mandy, I will go ahead and turn this over to you. And I just want to say to our panelists today, or the ones that have joined us, if you have any questions, again, please go ahead and chat those to us. And at the end, I will go ahead and shoot your questions over to Mandy so she can answer them. So Mandy, go ahead.
All right, thanks. I did not realize you were going to read all this. That's okay. So I'm Mandy. Thank you everybody for joining us today. And I want to thank Danielle and Laura from NAMI and Marshmallows Hope for inviting me to be present. There's some awesome organizations in the area here. This is a topic that I'm super passionate about. I'm grateful to be here. I'm also super nervous, so I apologize if I talk really fast. If you can't hear something, then just let me know. So yeah, I started Dahlia Center for Perinatal Mental Health just like a month ago. So it's my private practice, and it just focuses on prenatal and postpartum mental health. And I do telehealth all throughout Illinois. And I've been really excited to do that. And I do also just have to say that this is only for educational purposes and it's not medical advice. And see your doctor if you have a medical concern. Okay. So what are perinatal mood and anxiety disorders? So these are also called PMADs, and they include prenatal and postpartum depression, anxiety, OCD, bipolar disorder, PTSD, and postpartum psychosis. It's very, very common. Up to 1 in 5 pregnant and postpartum patients experience PMADs. They are the most common complication of pregnancy, and also nobody knows about them. And for patients living in poverty or in other high-risk groups, it can be as high as 1 in 3 people that have them. It's really important to note that it's not only pregnant patients that can experience PMADs, their partners can have it too. 1 in 10 fathers also experience PMADs, and these rates are even higher in LGBTQ partners. The highest risk factor for the non-pregnant partner to develop postpartum depression is the pregnant patient also having it. And they can also be experienced by adoptive parents and also after pregnancy loss. So it can be a really difficult situation and a big strain on the relationship if both partners are experiencing it. Nobody feels supported, and a lot of times they don't even know what's happening. They just kind of think their partner is not helping them or not doing what they're supposed to do. So current research is showing that untreated mental illness in pregnancy and during the postpartum period has a lot of serious effects, both on the patient and on the future development of the child. Everyone's always worried about the effects of medication on the baby, but most people don't realize that the mental illness itself can also have effects on the pregnancy. Many OBs and psychiatric providers and family members aren't aware of these risks. Symptoms kind of get brushed off as being normal, and all pregnant patients are moody and tired, and it's normal to cry a lot postpartum. Or they tell patients that no medications are safe, and they should stop them. And patients hear this and they get real nervous, and they feel like they just have to suck it up and it's their problem, and they're afraid to take medications because they don't want to hurt the baby. But not treating it has really big impacts. Suicide and drug overdose are the leading causes of maternal mortality. So more women die from suicide and drug overdose than even like high blood pressure and hemorrhage. And these are directly related to untreated mental illness. So the baby blues are super common. Up to 80% of postpartum patients experience it, and this is considered normal. So it's not usually a problem, it goes away on its own. It's usually just from the hormone changes after birth, not getting enough sleep, kind of adjusting to your new role. They can last up to 2 weeks postpartum, but they should be gone by then. Everything should have settled down. Symptoms include kind of weepiness, irritability, kind of just feeling a little overwhelmed and difficulty concentrating, but that they should get better with time. If the baby blues lasts longer than 2 weeks, it is not the baby blues. And if it's severe or includes thoughts that you or the baby would be better off dead, or you're seeing or hearing things, that's not the baby blues. Also, if you have pre-existing mental health problems and they come back or get worse postpartum, you don't need to wait for that 2-week period to see if it's going to go away or if it's real. It is, and the sooner you get it treated, the better. And up to a year postpartum. So there's kind of a big span where you can have these symptoms and they're considered PMADs. If they're not treated, they can last for years. It just turns into regular mood disorders, and it just lasts and lasts, and it needs treatment. Symptoms of depression include feeling sad, feeling numb, unable to enjoy things, mood swings, crying a lot, kind of withdrawing from friends and family, difficulty bonding with the baby, just no energy, feeling hopeless and worthless, feeling shame and guilt, or like you're a bad parent. Lots of people know about postpartum depression and that they should kind of be keeping an eye out for it, but don't know about postpartum anxiety or realize that that's even a thing. So symptoms of postpartum anxiety can be feelings of dread or that something bad is always about to happen, getting easily overwhelmed by noises or touch, having racing thoughts, feeling kind of on edge, having that like racing heartbeat and chest tightness and panic attacks. The thoughts are a lot of times focused on your parenting ability, feeling like you're a bad parent, or you're worried about the baby's health, development, and safety. Rage is also a huge symptom of postpartum depression and anxiety, and most people don't realize it. Sometimes rage is the main symptom that you have, and you might not think that you're having some depression or anxiety, but that's what kind of the root of it is. So like I remember being set off by just the smallest things. I would just get like instantly angry at our dogs when I just gotten the baby to sleep and their nails clicked on the floor and they might wake up the baby. And it was just completely over the top. Like, I don't need to be mad about that, but I just couldn't help it. So it's just that kind of instant rage that you can have. There's also postpartum bipolar disorder, which is periods of depression with periods of mania. The first episode can often present during pregnancy or the postpartum period, and a lot of times it's misdiagnosed as just kind of straightforward postpartum depression. There's two types of bipolar disorder. Type 1 is more severe with more severe mania, and it lasts at least 7 days, and there can sometimes be psychosis with it. Type 2 has like a less severe hypomania, but more periods of really severe depression. And symptoms of mania can include like not needing much sleep for days at a time and feeling like I'm still good to go. I have more energy than I know what to do with, kind of racing thoughts, difficulty concentrating, feeling like you're Superwoman and can do anything, taking on like new, suddenly ambitious projects and taking more risks than usual, like having more unprotected sex or gambling or spending too much money. So like painting and decorating a room is a normal thing for people to do when they're getting ready for the baby, but like suddenly staying up all night for days at a time to paint a huge mural on the wall, and you're dancing to lullabies, and buying a whole bunch of things and going into credit card debt for the baby is not normal. So mania doesn't always have to be happy. Sometimes people think mania and it's like really high and up there, but it can also be irritability and agitation and starting fights. Yes, the crappy mental illness, well, you have to be cautious if you're too happy and productive. That is correct. There's also postpartum OCD, which most people don't know about. So OCD is recurrent, intrusive, disturbing thoughts that are then followed by obsessions and rituals that are meant to prevent these thoughts from happening. The thoughts are super vivid. The images just pop in your head. They don't have control over them. And the patient fears that the thoughts might come true or that they might act on the thoughts. And so then these obsessions and rituals are done kind of to prevent that from happening. 80% of patients experience some intrusive thoughts postpartum. They're super common, but for some people, the thoughts are more frequent, more intense, and cause more anxiety. So they might have thoughts of, they see themselves throwing the baby down the stairs. So they'll walk as far away from the stairs as possible and hold the baby really tightly. They might imagine the baby suffocating in their sleep. And so they're constantly checking the baby monitor or staying awake to watch the baby breathe to make sure they're okay. Or they see themselves stabbing the baby with a knife. And so they avoid the kitchen altogether. And so patients think they're going crazy and they feel a huge amount of shame and, how could I think this? I'm a terrible parent. How could I do this to my baby? But they're just intrusive thoughts. They don't want to act on them, which is a big difference between postpartum psychosis, which we'll talk about in a second. There's also postpartum PTSD, which is post-traumatic stress disorder. It can be from the birth itself, or it can be related to previous trauma, like physical or sexual abuse that came back to the surface during the birth because something about the birth process reminded them of that experience. So symptoms have to be present for at least 1 month, and they can include persistent re-experiencing of the trauma. So that's like, nightmares and flashbacks, avoidance of stimuli with the trauma. So, you avoid the hospital where you give birth, or you can't watch Grey's Anatomy because the beeping of the IVs in the background like sets you off. Negative changes in mood and cognition. So feelings of detachment, trouble remembering things, depressed mood, and then increased arousal and reactivity. Includes like difficulty sleeping and concentrating, irritability, hypervigilance, which is kind of like always looking over your shoulder, thinking something bad is about to happen. Prenatal anxiety is the biggest risk factor, but both depression and anxiety are often found with PTSD. And so The birth doesn't need to be like traditionally traumatic where, it ends in an emergency C-section or there's a big hemorrhage or anything like that. It could just be someone who wanted an epidural, but they had a really fast and intense labor and didn't have time to get it. And so they were completely unprepared for that experience and how to cope with the pain that they felt. Or someone who had a really, really long labor and then they pushed for hours and then they had a bad vaginal laceration that needed a repair and they couldn't hold the baby because they were too tired. So it doesn't have to be that kind of big dramatic emergency situation to have the PTSD symptoms from it. You can also get PTSD after pregnancy loss. And newer research is also showing that up to 70% of patients with a baby in the NICU show symptoms of PTSD, depression, or anxiety. So that has been really ignored as a risk factor. And so, there's kind of starting to screen in NICUs for that because it is so common. And then postpartum psychosis is rare, but let's see, yep, I'll talk about that in a second. It's a medical emergency when that happens. The biggest risk factor is a personal or family history of bipolar disorder. And so more recently, the research is kind of thinking that postpartum psychosis might actually be on the bipolar disorder spectrum. And it responds really well to medications that are used for bipolar disorder. The symptoms begin suddenly and include delusions, hallucinations, extreme irritability, paranoia, and rapid mood swings. A lot of times the thoughts are very similar to someone with postpartum OCD, but instead of being afraid of those thoughts and trying to prevent them and they seem like horrible, they might think that they're reasonable or a good idea. So they might think that the baby is possessed and they need to drown the baby to save them. And that seems like, a rational thing to do. Let's see, we have a couple questions over here. Yes, so Suzanne, I will talk about that in a little bit with the connection between kind of past traumas and PTSD there. And Beth asked, yeah.
Sorry, Molly asked a question. It says, what kind of services support does Dahlia Center offer for women with chronic mental illness that want to have a baby?
Yeah, so I do preconception counseling. So, trying to make sure the medications that you're on are low risk for pregnancy, trying to get things stabilized before pregnancy. And then during pregnancy and postpartum, kind of medication management, supportive therapy, and that kind of stuff. The onset of PTSD, like not really surfacing or manifesting right away. So yeah, it can be, people are really good at kind of repressing their traumas and not dealing with things when they happen. And, years later, something might come up that reminds them of that. And it's very frequent for kind of birth and the postpartum period to be that trigger because it is so physical. It's very vulnerable. There's a lot of touch and that kind of thing. So it's very common that, something from childhood suddenly comes back to the surface. And they are completely, not expecting it or ready for it. And then, is there a difference between inability to sleep from being overtired and this decreased need for sleep? Yes. So the inability to sleep from being tired usually is more associated with anxiety. So you're laying there and you're just thinking of all the bad things that might happen, and your brain is going and going and going, and you're replaying everything that might have happened that day. But the next morning, it's like, I wish I could sleep. Like, I wish I could take a nap right now. I'm so tired, but I just, I can't. Versus like the mania or hypomania is like, I got 2 hours of sleep for the last 3 days and I am good to go. Like, who needs sleep? I got stuff to get done. Like, let's do this. So there's a difference between not being able to turn your brain off and get sleep, but missing it, and then not missing it at all and feeling like, yeah, this is pretty good. I could do this. It also has to last for more than just a day or two. Everybody kind of has, a day where they're like, I didn't get any sleep last night, but I feel fine, but for mania, it's more multiple days in a row where somebody who wasn't manic would eventually like crash and be like, oh my God, please let me sleep. And they're still good to go. Okay. So there is also something called dysphoric milk ejection reflex. And this isn't really considered a PMAD, but it's something that can affect mood that many people aren't aware of. So it's not really well known. It's not really well understood. It's only been like recognized in the last 10, 15 years. But it's an intense feeling of anxiety, panic, agitation, or doom that occurs during letdown and lasts 30 seconds to 2 minutes. And it's caused by the sudden drop of dopamine during letdown. So symptoms can last 3 to 6 months, sometimes last over a year, but it's only during letdown. So sometimes people, like when they're pumping, it's just this, they're getting ready to pump, they are ready to go, and it's during letdown, it's just like this intense, like, oh my God, I can't do this right now. I'm, completely like, get this off of me, agitation. But it does go away. But for some people, it can be pretty intense to the point where they don't want to keep nursing anymore because it's too uncomfortable or distressing. Yeah, intense despair and impending doom. Exactly. There's not really a treatment. They're kind of looking into the antidepressant Wellbutrin to see if that works, because that can help increase dopamine, but it's all still very experimental. So some of the risk factors for PMADs, the biggest risk factor is already having a mood or anxiety disorder and not having it adequately managed. Because if it's already there, there's such a big chance for it to, feelings last longer than letdown. So it's usually, it can be a minute or two, but it shouldn't be like, for a whole half-hour nursing session, you're like, God, I hate this. This is awful. That's probably more along the lines of some depression or anxiety and struggling with some nursing issues versus that sudden drop in dopamine where it's like a very sudden and intense feeling. Also having a PMAD in a prior pregnancy or postpartum is a big risk factor for developing it again. And they're also thinking that it's not necessarily the drop in hormone changes, the drop in hormones, but it's just the change itself. So there's not really a set, everybody experiences this change in estrogen and this is happening, or this is their progesterone level, and so now they're having the symptoms. It's the way that you respond to the changes. So PMDD, premenstrual dysphoric disorder, if you are somebody who gets the real extreme PMS symptoms, that can mean that you're also more susceptible to developing a PMAD because it's those similar hormone changes there. And you can also get this when you stop nursing too, because that's another change in hormones. And if you are breast or chest feeding and it's going well, that's considered a protective factor. But if you are struggling or having a hard time, it can increase the risk for developing symptoms, which kind of makes sense. If you're feeling good about it, it's going well, then, you're not really worried. But if you are struggling or anxious or, the baby's crying a lot and not latching, you're not sleeping well, that's going to increase your symptoms. And it can be this circular feedback thing where, you are depressed and anxious, and then you are struggling, and then it gets worse. Or, maybe the baby has latch problems. And so then that leads to the lack of sleep and the mood changes and anxiety. So it's kind of a chicken and egg thing there, but it is a risk factor. So how to prevent them? So one of the best things that you can do is to adequately treat your mood and anxiety disorders to prevent relapse. You would ideally want to be kind of in a stable place before you get pregnant, but that's not always possible or realistic. So you do still want to kind of aggressively treat things if they're there. If there's a history of postpartum PMADs, you can consider taking prophylactic medication that you start during delivery or right immediately postpartum, even if you're not having symptoms yet. That way you can kind of prevent them from happening. So sometimes people, they're like, I don't have symptoms during pregnancy, and so I don't want to take a medication, but they had real bad postpartum depression before. And so sometimes people are more comfortable waiting until after the baby's out before they decide to start something. But that is an option, and it does help prevent things from getting severe again. If you are one of the people who's at risk for PMADs, you can request an early postpartum mood check appointment. This would be with either your psychiatric or your OB provider. Just to make sure that they know it's a postpartum mood check appointment, so that it's not just treated as like a regular postpartum appointment where kind of mood is an afterthought. Sometimes you might not realize how bad it is, or that what you're experiencing is actually treatable, and it's easier to catch things early than to wait until they're bad. There's different screening measures that you can get them online, but a lot of times they use them in the office. So like there's like the PHQ-9 or the EPDS for depression. And then there's the GAD-7, which is for anxiety. So you can take those online if you're kind of like, oh, maybe I do have some symptoms. Let's see where I'm at with this. And they're screening measures, and they can just kind of give you an idea of where you're at. There's also the MDQ for bipolar disorder. And again, it's just a screening measure. It's not diagnostic, but it just kind of points you in a direction of, like, maybe this is a little more than just, not being able to sleep or something. One of the biggest contributing factors is not getting enough sleep. So everything is worse when you're not getting enough sleep. If it's because you're waking up every 2 hours to feed the baby, or you can't fall back asleep because you can't turn off your thoughts. It doesn't matter. You're not getting the sleep that you need. And so it makes it really hard to function. So ideally, people would get at least 3 hours of uninterrupted sleep a day. 4 is better. 6 would be awesome, but that can be kind of hard with a new baby and different partner schedules and how much support you have. Sleep doesn't have to all be at night. You can take a nap during the day. And that 3-hour nap is fine as long as you'll actually sleep. So, if you're going to sit there and you're going to lay in bed and worry about, what's going on outside, or the dog's going to keep you awake barking, or, something like that, then some sleep is better than none, but try and make it when you'll actually be able to sleep. And then if you are a patient who has more severe bipolar disorder or a history of psychosis, or even really severe depression and anxiety, where maybe you've had to be hospitalized or there was a suicide attempt with it, there should be a sleep plan in place ahead of time where you know that you can get that dedicated sleep. Your support team knows how important that is and why you're doing it. It's not just, oh, she just wants to sleep all the time. It's like, no, I need to so that I can function. And I can keep myself in a good place. So some places will For those more kind of patients with severe illness, they'll keep them an extra day in the hospital so that they can monitor their mood a little bit more closely or make sure they're getting sleep. And, not a lot of hospitals do kind of the nursery anymore where they take the baby, but sometimes they'll make exceptions for these kinds of patients where, we're going to bring the baby to the nursery. You're going to sleep for this amount of time. We're going to give you medication to help you sleep. And we're going to try and prevent things from getting bad in the first place. If you're breast or chest feeding, that can make sleep more difficult. You can't share the responsibility as much, but you can try and have your partner bring the baby to you so that you can kind of sideline nursing and you can try and sleep through it. You can also try and pump before laying down and have your partner give a bottle, so that you can you can skip a feeding and they're taking care of the baby, or they can give a bottle of formula at a set time of day. And as long as it's consistent, your supply should adjust around that and it shouldn't affect your supply much. But those are all kind of ways to try and get that chunk of sleep in there. It's a good idea to join a lactation group or find a lactation counselor ahead of time. That way you already have your support in place, you're comfortable with the people, you know who to call if you're having a problem. And if you're pumping, set it up ahead of time and know how to use it. I can tell you from personal experience that 2 a.m. with a screening baby is not the time to be trying to figure out how to use it. So know how to use it ahead of time, make sure your parts fit, you have everything you need, and have it ready to go. And if you're struggling with nursing and it is making your mood symptoms worse, it is absolutely okay to either supplement with formula or switch to formula. Any benefits of nursing are more than canceled out by any problems it might cause with your mental health. So don't feel, everybody feels guilty about everything being a parent anyway, but try not to add that onto your guilt list. Some other things you can do. Identify your support system ahead of time. Know who is going to be in your corner, who you can call when you're having a hard time, who's going to come and help you. Have a list for people that you can just kind of post on the fridge of, when people come, have them help. And it's really hard on the spot when somebody says, hey, what can I do for you? To be like, let me come up with something real quick. Or you feel, like, oh, I don't want to be a burden. But if you just have this little list available and let them know it's there, they can pick something off of it and, you don't feel so on the spot. So some things that are really helpful would be, picking up a curbside grocery order for you so that you don't have to try and go out, in the store or in the weather. Vacuuming, making a simple meal or bringing food, doing your dishes, watching the kids so you can take a shower or a nap, helping with the pets because they're always so neglected in the beginning, and anything that will make your life easier. We pretty much had everybody bring us food if they wanted to come and see the baby, and that was like the toll that they had to pay. Set the expectation ahead of time that you're not going to be entertaining people and that if they want to visit, they need to help. And this can be really hard depending on kind of your family dynamics. But start early, letting people know that this is not a social visit. You are not, gonna be cooking dinner and, entertaining them. And, they can visit and see the baby, but this is not going to be like an all-night hangout session. Consider hiring a doula. So doulas are dedicated support people that help you cope during labor and postpartum. Lots of people think of them for labor, but they also do postpartum work as well. And they are amazing and everybody should have one. Stock up on freezer meals, grab, quick grab and go snacks as much as possible. And like I lived on trail mix and granola bars in the middle of the night while I was up feeding the baby. probably too much. I didn't probably need to eat every 2 hours a whole granola bar and everything, but one for you and one for me. So try to avoid isolation and staying indoors, which is really hard to do during COVID in the middle of winter, but it's important to try and find ways to do that safely. So whether it's doing Zoom stuff or finding a support group or having a little bubble of people that you can interact with safely, it's really important not to isolate yourself. Try and have realistic expectations, and that can be really hard if you're somebody who is on the kind of anxiety side of things, but it really is okay if there's dishes in the sink, and it's okay to set the baby down so you can eat or go to the bathroom. Sometimes people feel like they have to like completely just abandon themselves and their needs in order to take care of the baby, and that's not true or practical. And you still get to have personal boundaries as a parent, and they might not quite be exactly what you would have in your normal day-to-day life, but you still get to have them. And so it's okay if the baby cries for a few minutes so that you can feel like a person again and get your patience back. So we were really big on, we had a yes space, which is basically like a completely, we did a kind of a playpen in the corner, but a completely baby proofed area where, if you need to go do something, you can put the baby in there and know that they're safe. And you can go, make your coffee or go pee or whatever it is. You don't have to feel like you can't do that stuff. And baby wearing is also something that is great for when they're little, or if you have other kids, so that you can still be able to move around and function while still being close to the baby. So when you're getting ready for delivery, there's certainly some things to think about. Planning ahead is really important for people with a history of trauma. I don't hear you talking. So I'm going to assume that you're muted, but it would be like a little microphone with a cross through it. Yes, fussy babies are absolutely triggers for PMEDs. So any high needs babies can set it off. So labor and delivery, C-sections, and breast or chest feeding can be very triggering. Prior birth traumas can increase anxiety during the current delivery. If you had a bad experience and you're going into this expecting another bad experience, then you're obviously going to be more anxious about it and concerned. If there is a history of trauma, try and get some trauma specific therapy prior to delivery. It's a good idea to do anyway, but if you do think that it's going to set something off having the vaginal exams or anything like that, then it's a good idea to try and address it ahead of time. If there is something that's particularly triggering for you, let your team know ahead of time and let them know what it looks like if you do start having a panic attack or a flashback, and what is going to help you through it. You can write it out if you want to, and give it to them so that you don't have to repeat it throughout the labor process, or give it to your support person and then have them kind of reinforce for people what you do or don't want. So more providers are starting to use trauma-informed care, where you kind of just basically assume that everybody has a trauma history, and because you don't know, and you treat everyone from that perspective. But unfortunately, in obstetrics, that's not kind of historically the view that they've taken. So this is something that you do want to talk ahead of time with your provider about. You really need to be able to trust your OB provider. You need to trust that all touch is going to be consensual. They should, get your permission before touching. If you tell them to stop, they should stop. if they make you uncomfortable with how they handle exams during your prenatal appointments, it's probably not going to be any better during kind of the labor and delivery process, because there is so much focus on the baby at that time that, if they were bad about it before, they're really going to be bad about it when you're in labor. So consider how that will affect you and decide if that's somebody that you want on your birth team. And then labor and delivery can also be pretty triggering for the LGBTQ patients. It can cause a lot of body dysphoria. There's a lack of inclusivity. So there's lots of mothers and fathers and, mama, you're a birth goddess. And there's kind of over the like, no. So if, always talk with your birth team ahead of time and let them know what appropriate language is for you and your family. Ask them to put it in your chart so that you don't have to keep, bringing it up or correcting people. So kind of consider what mood you're going for, during the labor process. We don't always get to pick, but if we can, then, are you somebody who just wants really quiet and peaceful and you can focus and be undisturbed? Or do you want it to be, kind of distracting where you can be laughing and playing games and having fun and listening to music? And, it's just kind of the tone that you want to send. And some people, want it one way and some people want it another, and that's fine. And there is a lot more that you can do in the delivery room kind of than what people think. You can ask them for dim lighting, you can play music, you can ask them to not talk as much or keep conversations to a minimum. You can request that you don't have students or extra people in there. So don't feel like, you have to be like on display for all of the students in the world, and you need all of the bright lights on, and it needs to be like this chatter back and forth of who's had what for lunch today, and just let people know, or have your support people let people know, because that's not something that you should have to worry about. A partner, a close friend can be super supportive with the LGBTQ a pregnant person by taking the burden of making sure medical professionals use pronouns. Yes, exactly. So, ideally, again, that the providers and nursing staff and hospital staff and everybody would kind of be aware of these things and inclusive of these things. Unfortunately, that's not always the case, and it should not have to be the pregnant person's responsibility while they're trying to, have this baby. So put that on your support people. Absolutely. Also consider, some people kind of want a more natural birth process, and the thought of being induced increases their anxiety, and they want to avoid that if at all possible. And other people really want a scheduled induction so that they can kind of plan and have their support team in place. And they know that, my partner can be off for 2 weeks and it's going to be these 2 weeks and this works best. And, it just kind of depends on what your style is. And they're both valid either way. So don't feel like you have to, do one or the other, especially if it's for your mental health. And think about pain control ahead of time. Some people don't like the feeling of not being able to move with an epidural. It can be kind of a weird feeling, or some people feel kind of trapped when, they can't move their legs, or, they don't have as much sensation. But for other people, the pain of labor increases their anxiety and makes them more likely to have a panic attack. So, personal preference, whatever is going to work best for you. And if you don't want an epidural, though, make sure you try and practice some coping techniques ahead of time to help you deal with the pain. Because there's lots of times where people think like, I have a great pain tolerance, I can just go in there and it's fine. And then they start, getting into active labor, and they're like, this is not what I thought it was going to be. So if you have these techniques that you can practice ahead of time, then it's a little bit more comfortable for you. Um, and doulas are great again, whether you get an epidural or not, especially if you are a person with anxiety. They support you. They are also good at supporting your partners too. So your partner can focus on.
Hey guys, it looks like we are having some technical difficulties. I'm not sure if it was Mandy's system that froze or can anybody hear me? Um, I'm still showing that we're live, but I think that we lost Mandy. So hopefully she can come back on here. I do apologize for that. It seems like maybe she froze and then we had a disconnection. And everybody can see my video okay? Let's just give it a couple minutes. Okay, thank you guys so much. So we'll give it a couple minutes to see if we can get Mandy back on. She definitely has some amazing information. And just remember that if you guys have any questions, go ahead and put them in the Q&A or in the chat. And then at the end of the session, I'm going to go ahead and read those out to her. And she's been doing really well as far as keeping up with the chat and answering you guys' questions. But, you know, if there's anything that you want to know, I will be, if we can get her back on here. I do believe that this recording will be available online on our NAMI Northern Illinois webpage or Facebook page, actually. So yes, I do think that it will be available. It definitely is very helpful, very insightful. So, okay. And I apologize so much. I'm not sure what happened, but I'm going to try to send her an email. Yeah, exactly. Gotta love technology. Okay. Well, if she doesn't come back in a few minutes, then we can always try to reschedule it again so that she definitely can finish because we believe that it's great information and you know, it's something that's very necessary for us to put out to the community. And hopefully you guys are finding it helpful and are enjoying the presentation. Of course, Candace says, thanks for the informative presentation. Absolutely. Okay. So for those of you who are still with us, we're just giving Mandy a couple minutes to see if hopefully she can log back in. I just wanted to let you guys know to check out the NAMI Northern Illinois website and also our Facebook page. If you guys know of anybody who is living with a mental illness, NAMI offers amazing support groups and they're free to the community. We have a parent support group. for parents of children who are living with a mental illness. We meet on the second Saturday of every month and the fourth Wednesday of the month. So you can go on the NAMI website, NAMI Northern Illinois.com, or you can go on the Facebook page to find out the times. We also have a family support group. We have a Group Hope teen group, a young adult group, and then also an adult group. And then we have our connections group on Sundays. They actually meet every week. And that group is for people who are living, adults who are living with a mental illness and need that additional support. So these are amazing groups. If if you know of anybody who needs that additional support, those are available to you guys. And that's, one of the great things that NAMI does for the community. And you're very welcome. So, give me if you guys will hold just one more second. If I'm going to try to get in touch and see if we can get her back. And then if not, we'll go ahead and disconnect. But give me just one moment, okay? I will be right back. Here she is. Let's see. Okay, we have her back.
Technology is awesome.
Yeah. Hey,
All
glad
right.
to have you back. All right, awesome. So I will go ahead and give that back to you and just have at it. We still have a bunch of participants that are here. So,
Oh, well, thank you for waiting. I appreciate it.
no problem.
Okay, so we were at some of the delivery considerations. Thinking about pain control, using a doula. Okay, so if things don't go according to the textbook, think about how you would like that handled. So are you a person who wants to be a part of all of the decisions? You want to discuss with your support team before anything gets decided? Or kind of are you somebody that, if things aren't going well or something's going wrong, that you will get overwhelmed and can't make a decision, and you just want to trust your provider and to make the best judgment call for you? And obviously you want them to tell you what they're doing, but some people don't want that responsibility and other people do. So either way is fine. Just talk with your provider ahead of time and let them know kind of what you're looking for. And then in the event of a C-section, or even for a scheduled C-section, you can request some things to make it a little bit more comfortable for you. So waiting until you're numb before they insert the catheter. I don't know why, but that doesn't always happen. Avoid strapping down your arms. So they're not usually strapped down like tight, but they'll put little loops around so that people don't accidentally, hit the sterile field, or, the arm doesn't fall off. But, you can request that they maybe don't do that if that's going to be something that's going to really set off your anxiety. Some places have clear drapes so you can see the delivery. I don't think anywhere in Rockford does, but there are some other places that do. And so it's always worth asking. And if you think being in the OR is going to be overstimulating, too anxiety provoking for you, you can wear headphones or earplugs and, bring an eye mask, or even just put a towel over your eyes so that you don't have to see all of the lights and hear, all of the machines beeping and, everything that's going on. So you certainly don't have to just lay there and, have a panic attack if you think that there's something that can be done about it. So as far as partners and other birth support people go, there's a few conversations that can make a really big difference. So, talking about your different roles and expectations, and what you expect of the other person and of yourself. And after the baby is born is not the best time to find out that your partner expects you to do all the baby care and their contribution is going to be going to work, or that you're going to be the one that's always waking up at night with the baby, or different parenting styles and philosophies. Does somebody is somebody really set on gentle parenting or attachment parenting, and somebody else believes in spanking. And so those can kind of cause some conflicts down the road. So just having, very honest, but, non-defensive talks about it is easier said than done, but it's important to try and do. Talking about visitors. Are you going to have them at all? How soon do you want them? Some people, pre-COVID days wanted a party in the hospital, like right after the baby came out. Other people like to have a few weeks of I'm just getting used to my family. And, I just kind of want it to keep it to us for a little bit, and then we'll start inviting people over. And are you going to have people come and hang out, or is the expectation just, they're going to come and meet the baby, and maybe they're going to, bring us some food and we're going to eat lunch and then they're going to go. It's very personal, and definitely talk about it ahead of time, because if somebody's a social butterfly and somebody is more private, then that can conflict a little bit. And talking about how you'll handle grandparents. Or is your partner gonna stick up for you if your grandparents, if the grandparents are giving you a hard time about something, or you're struggling and they're not having a great relationship with you? Are they going to be in your corner, or do they just kind of side with their family? And everybody has different relationship dynamics, but if that's kind of the way that your family is set up, then you might need a little bit more support somewhere else than just from your partner. And then the Postpartum Stress Center is another awesome organization that has tons of information, but they have a really nice handout called Our Postpartum Pact that I would recommend everybody print out, kind of go over together and post somewhere visible if they find some stuff on there that seems like it really resonates with them. So it has things to look at, like your partner's going to look out for, is there anything I'm saying or doing that seems out of character? Am I reacting appropriately to the baby? Do I seem detached from the baby? Am I too scared or too tired to do what I need to do? Or am I telling you I made a mistake and I don't want this baby? So you can kind of give your partner a heads up of some, like, hey, these are some red flags that, maybe I'm not doing okay, even if I say I am. And then also on that list, they have, things that your partner can do or say to help you if they notice you having a hard time, or things not to do or say. And then, if they do notice something, how do you want them to handle it? Like, should they bring it to your attention? Should they bring it to your family? Should they try and really get you to go to the doctor? Or, is it more like you want a gentle nudge kind of thing? So, nobody knows exactly what they want until they're in the moment, but, you kind of know generally how you respond to different things. So always good to know ahead of time. And the opposite is true too. If you have a partner, if you are the pregnant person and you have a partner who is struggling with a perinatal mood and anxiety disorder, that can, these apply to them as well. Let's see, I lost, oh, there's the chat box. Okay. Okay. So before we get to treatment, there were a couple of questions. So for someone who has bipolar 1, how can you tell the difference between a depressive episode and paranoid episodes look different, or is depression? So if you know that the person already has bipolar 1, then you're going to treat it like that. Just, assume that this is all part of the bipolar disorder, and you're going to be really proactive with it, especially if it's bipolar 1. For somebody that has no history of any mood or anxiety symptoms, it can be a little bit more tricky, especially if it's depression and anxiety together, because a lot of times anxiety can look like, some hypomania, or it can kind of have some of those flavors if it's bad enough. Or there's mixed episodes where, people are manic and depressed at the same time. And that can be hard to tell, like, is it just irritability from postpartum depression? Is it irritability because they're also having a mixed episode? So probably if it's just straightforward, kind of not super severe depression, and there's not a lot of those kind of mixed features where it's more straightforward depression, then it's probably okay to start conservatively treating it as depression. But also kind of, you'll want to look at, like, is there a family history of bipolar disorder, or have they taken an antidepressant before and had kind of a bad reaction to it? So those are all kind of more like soft signs that you can look at of maybe they're more on the bipolar spectrum than just straight depression. So I don't know if that answered your question or not, but it can be tricky to tell the difference. And then, how common is it to be over anesthetized? I legit couldn't breathe and I thought I was going to die. So I wouldn't say that it's common. It does happen, but it can also, because of the way that you're laying, and if you have not actually seen a C-section before, it's very physical on the other side of the curtain, and there's a lot of pushing and pulling, and so that in and of itself can make it, short of breath and difficult to breathe. And when you're pregnant and you lay on your back, usually they try to keep you tilted, but sometimes they can't quite do it as much as they'd like because they can't see what they need to be doing. And so even that can just make you feel like you can't breathe. So I wouldn't say that it's super common, but it is common for people to have some pretty strong anxiety reactions with it too, where not at anything that's like a dangerous level, but it's really uncomfortable feeling to feel that way. So I don't know if that answers your question or not, but I would say it's not something that most people should go in expecting. For treatment. I'm trying to arrange my screens here. So there is absolutely no shame in getting treatment. The best way for you to take care of your baby is to take care of yourself. And, everybody, I shouldn't say everybody. I know I was very proud and had a hard time accepting that maybe I had a little touch of anxiety, but it can be hard for people to realize that this isn't normal and it doesn't have to be like this. And, just kind of look at the way that you're parenting, and is it the way that you want to be parenting, or do you find that you're having a lot of that kind of rage reaction and not responding to the way that to the baby that, in the way that you maybe would want to. So getting treatment is way more important than just trying to put it off and put it off and put it off. Ideally, you try to find a provider trained in perinatal mental health. It is hard to find. Postpartum Support International has a provider directory. They're the ones that do the perinatal mental health certification. They have a whole directory of different providers, therapists, medication prescribers. I think they even have some like lactation consultants and doulas in there that are specifically trained in perinatal mental health. And they also have local peer supports that are kind of more familiar with your local resources. And getting that person that's trained in perinatal mental health can make the difference between telling if it's, a depressive episode or bipolar disorder in the postpartum period, and kind of teasing that out. And, what is normal kind of mood changes for postpartum, and what's kind of crossing that line where, maybe we need to take this a little bit more seriously. Sometimes too, with some of the OCD thoughts and things like that, if it's an untrained professional, sometimes they, the patient finally opens up and they want to get help, and they tell the provider what they're thinking about, and the provider is like, I don't know what to do with this, so I'm gonna, I don't know. And so, they don't know, okay, this is postpartum OCD. That's what this is. There's a name for it, and we can take care of it. And they're just kind of generally going to be more comfortable managing medications in pregnancy. And know what the current research shows. And yes, no problem. And if you or your partner start to notice symptoms, try and talk with your provider as soon as possible. It's, it takes time to get in for an appointment, but it's always easier to catch things early rather than to try and chase it when it's already bad. And then another thing to really keep in mind is that anemia and thyroid problems are very common postpartum, and they can cause a lot of symptoms that can kind of mimic some of these mood and anxiety disorders. And so if you find that you're struggling with some of these symptoms, then ask them to run some labs if they're, not offering to. Because if it's something as simple as, hey, your iron's low, that's why you feel tired and crappy, then you can take some iron supplements and make that feel better. So, try and get to the root of it if there is a root and it's more than, kind of postpartum stuff. Also, low B12, vitamin D, and folate can increase fatigue and some of those other symptoms. So, sometimes if it's really severe, you don't have time for the supplements to wait to start working. And you need medication either way. But, if it's kind of more on the mild side and your, thyroid is abnormal and you're going to take some Synthroid and, in a couple weeks, you're going to feel great, then maybe it's okay to wait and see how you feel once that's corrected. Let's see. So for mild to moderate anxiety, depression, and PTSD, the recommendation is therapy. So you don't have that extra exposure of the medication. Even in the lower risk medications, it's still something extra. And if, therapy is going to help you work through it and that's going to, get you through it, then some people don't want therapy and they only want medication, and that's fine too. It's totally personal preference, but generally the recommendation for mild to moderate anxiety is therapy. Also for mild and moderate, you can do some more of the kind of vitamins and supplements. So magnesium helps with anxiety, fish oil, B complex can sometimes help with some energy if that's low. If you have an MTHFR mutation, then taking methylfolate can help your brain kind of produce those better neurotransmitters and kind of get you back up there. Talk with your provider, but all of these things are generally kind of safe and helpful. They just take longer to help and might not treat some of the more severe cases. Sometimes people ask about herbal options, and some of them do have evidence of effectiveness, like St. John's wort works for depression, but it isn't super well studied in pregnancy and nursing, and it has a lot of medication interactions. So definitely don't just start, get it off Amazon and start taking it while your provider is trying to do all these other medication changes and things, because that can cause some really bad side effects. Exercise and nutrition are always on the list, and they definitely do help, but They can be hard to start when you're kind of exhausted and can barely manage to like brush your teeth or get out of your pajamas. So, always kind of maybe be working towards that, but cut yourself a little bit of slack. And, if you didn't eat, 7 servings of salad on that day, like it's okay. You have some bigger, things to work on first. There's mindfulness exercises and meditation. These work really good for anxiety and insomnia. There's lots of apps that you can kind of download now that you can listen to before bed, that kind of just give you something to focus on and, kind of settle your brain down just a little bit. So those are always really good. And then joining a support group is also helpful, especially now with COVID, to kind of avoid that isolation, give you a sense of community, and also lets you learn some new coping skills. Postpartum Support International, the same organization that I was talking about earlier with the provider directory, also has some free online support groups for lots of different types of groups. So if you don't have somebody local to you, then check them out. As far as medication treatment goes, so for moderate to severe depression or anxiety, or bipolar disorder, or any sort of psychotic disorder, medication is recommended first line. So it's recommended that you go right for the medication because those risks from the mental illness are much greater. Also recommend therapy, but it might not work fast enough to reduce those risks of the more severe mood disorders. A lot of people are afraid of medications, but when you're kind of weighing the risks and benefits, it's really important to remember that it's not risks of taking medication versus risks of nothing. It's risks of medications versus risks of untreated mood disorders. So, there was that whole long list of, side effects from having untreated depression and anxiety, and those are very real. And so, if you would benefit from medication and you don't take it, it's your choice either way. Obviously do what's comfortable for you, but be aware that you're not eliminating risk by not taking the medication. Most medications are okay to take in pregnancy and nursing. The only medications that are pretty much always avoided, except for like the most extreme situations, would be like Depakote and Tegretol, because those are known to cause some severe birth defects. But most of the other ones are pretty low risk. Lithium has a very small increased risk of some cardiac malformations in the first trimester, but it's also a really effective medication for bipolar disorder. So if somebody has that and the risks outweigh the benefits, or the benefits outweigh the risks, then it's okay to use. Same thing with stimulants. So stimulants, that would be like your Adderalls, they can increase the risk of high blood pressure, of preterm birth, and low birth weight. But if somebody's taking it for ADHD and the ADHD is severe enough that if they don't take it, they're going to get fired from their job, or they're going to get into a car accident because they couldn't focus while they were driving. That risk is much higher than any risk from the medication itself. So there's a place for it. And then benzos like Ativan and Xanax have a small increased risk of miscarriage in some of the research, and then a risk of withdrawal if they're used regularly. I personally don't use much of the benzos, but they can have their place for situational anxiety that is like small and limited. And, if it's severe, again, probably okay. For some, I don't know if you can see that screen or not. Let's see. So can a feeling of static, like in an old TV in your brain, be a part of postpartum depression or anxiety? Absolutely. So that can be part of the kind of overstimulation, where there's just a lot of noise in your head, and anything outside of that just puts you over the edge. That can sometimes be maybe more on like the numbing side, where you just don't really, it's just kind of, like an empty TV screen. Does that answer your question at all? Sometimes just being tired too can make you feel a little bit off, but if it's consistent, then it's probably more likely to be related to something with mood. Let me know if that didn't answer. So for medication treatments, a lot of the really common ones, hydroxyzine. I use a lot of hydroxyzine in pregnancy for Miss Molly Rose. So um, for some reason in the psych world, hydroxyzine is like a no-no in pregnancy, and I don't really understand why. Because in the OB world, we can use it for, some people use it for itching and uh, for nausea and vomiting and for sleep. So it's hydroxyzine is a medication that's sort of similar to Benadryl. That's just a kind of a different formulation, but it does work really good for anxiety and sleep. And so, I use it a lot for that. Or, if somebody is having trouble sleeping and they're having anxiety and depression and they're, taking Zoloft, but it takes a little bit for that to build up in your system and they need something sooner, then I'll kind of use hydroxyzine for that. I in the 8.5 years that I've been a midwife, I think I've maybe prescribed a benzo like 4 times. And that was a lot of times for like somebody's having a panic attack while they're in labor and, they need something right now. But I really try to avoid them. So let me know if that answered your question. Do you know what issue you would put that with? I'm assuming you're talking about the static noise, Lisa. I would say it could be either one, and it probably depends on what other symptoms you're having. So I don't know that I can really say just based off of like that only symptom. But that's kind of where it would be helpful, if you see somebody that does psych, sorry, I know, then they're a little bit more familiar with that kind of stuff and kind of can look at the big picture. I use a hydroxyzine replacement for benzos for substance use. Yep. And if it was good for pregnancy. Yeah, like I said, so I use it all the time in installs for, the medications. They say, no in pregnancy for hydroxyzine, but that's not the case. And it's very low risk it doesn't cause, birth defects or anything like that. So I don't know why it's not used more, but I think it absolutely should be. So SSRIs, antipsychotics, and lamotrigine are all low risk in pregnancy. I love Lamictal. It's one of my favorite medications. I think it should probably be in the drinking water, but they're all okay to use. So, there's some little risk factors that the research does show. It's really hard to kind of parse out what is due to the medication and what is due to the mood disorders, because a lot of times in the research they kind of compare here's these happy patients with no mental illness, and then here's these patients with depression and anxiety, and some of them take medication, some of them are taking the medication but it's not adequately treating their symptoms. There's other risk factors like substance abuse that can go on when you have untreated mental illness. And they look at those things, but they don't kind of say, well, this is due to the medication, or this is due to the depression and anxiety, or this is due to the substance use. So newer research is showing that they're very low risk and they really do what they're supposed to do. Antidepressants and antipsychotics have a small risk of what's called neonatal adaptation syndrome. Sometimes people hear that and they're like, oh my God, my baby's gonna have withdrawal if I take this Zoloft. It's not what it is. It's not a withdrawal like from opiates. It's just kind of an adjustment where they can be a little bit irritable, a little bit more jittery. It goes away on its own. There's kind of some doubt as to how big of a risk that actually is, because the scoring of it is very subjective. So, if you're the person that's scoring that baby and you know that the patient was taking a medication, you're probably going to look a little bit more closely versus somebody that, was not on any medication and had a low risk, uncomplicated birth, where you might just kind of attribute that to normal newborn behavior. So, some of that is some bias too, but it's not like an opiate withdrawal. Um, it's it's mild, and it's does not happen very often anyway. And generally, the recommendation is that if you're on a medication and it's working well, or you've been on a medication in the past that works well, that's what you should continue, instead of switching to a medication that maybe on paper is lower risk, um, but you risk the return of those symptoms and worsening of mood symptoms. The only case where maybe you would want to switch off would be like if you were on Tegretol or Depakote or something like that. But generally, OB providers love Zoloft. It's kind of drilled into our heads that that's the one that you pick. And so that's what they're comfortable with. OB providers don't have a ton of training in mental health. We kind of know the what to look out for and some of the kind of get it started kind of stuff. But you have like a couple medications that you learn about, and that's what you use. And you hear Zoloft, 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 and so everybody who's depressed is going to be switched to Zoloft because that's what I know and that's what I'm comfortable with. But that's not what the research recommends. Yes, I knew it, you might, Candace. Thank you. And so, if your OB provider, if you were taking a, different medication, say you were taking Lexapro and your OB says, okay, stop that and switch to Zoloft, that's not what the recommendation is. They should have you stay on the Lexapro, because it works, that it's low risk, that's keeping you stable. And that stability is the most important thing, because we know about all those risks that come along with mental illness, and we don't want to cause a relapse. Sometimes OBs will also stop medication in the 3rd trimester. There used to be an old recommendation that, we're going to wean off the medication by 36 weeks to try and prevent this neonatal adaptation syndrome. But research shows it doesn't make a difference in the baby, but it makes a huge difference in the mom and causes a lot of symptom relapse. And most medications are okay to continue while you're nursing, especially if you use them while you were pregnant. And it's important to use the lowest effective dose of medication and treat until symptom remission, which basically means that you are not experiencing any more of those depressive or anxiety or manic symptoms. Like you're at a good place. So sometimes people are still kind of afraid of medication, and they take like these little tiny baby doses, because they are like, I don't want to take a big dose. I want to just stay with this little tiny dose, but they're still having those symptoms. And if you do that, then you're exposing to the risks of both medication and the untreated mood disorder. So you really want to take the lowest effective dose. And if that means that you have to go to the maximum dose of that medication, then that's okay, if that's what it takes. And then generally, if you are on a medication, they recommend staying on it for at least 6 to 12 months after your symptoms are controlled. So that doesn't mean 6 months from the time you start the medication. It means 6 months from the time that you are stable and not having any more symptoms. All right, last one. So I can't stress enough how important it is to get treatment. That does not automatically mean medication. We don't always have to just throw medication at things, but if it would be helpful to take it, then take it. Just like some people kind of need glasses to see because of the way that their eyes work, and some people need insulin to treat their diabetes. Some people just feel better on medication because of their brain chemistry, and that's okay. It's important that you do whatever is going to help you function the best and take care of yourself and parent the way that you want to. So I would just like to, thanks again to NAMI. And if anybody has any questions, let me know. I will also put together like a handout with the information from the presentation somebody asked for. And if you want to leave your email address, I can send it over to you if you want it. So thank you.
Thank you so much, Mandy, again from NAMI, for being here. This was extremely informative. I definitely enjoyed it. And I hope that, a lot of people got to learn a lot of stuff from it. I mean, clearly. And so, yeah, if you guys have any questions, please submit them in the chat. Otherwise, if not, we'll give you guys a couple minutes and then we'll drop off.
All right. Thank you.
Thank you. Thank you for being here.
I'm just going to drink from my ridiculously big mug while we wait.
I'm so happy that you got to come back on too.
Oh my God. I was like, oh my God.
Yeah, I didn't know if it was me or if it was you. And so, but glad it worked out.
Yeah, no, my phone just decided that being a hot spot was too much for it. It just drained my battery.
Oh no.
Okay.
So it looks like there's a question.
Back on the charger.
It says, are there miscarriage specific support groups?
Together.
It's frozen again. Uh-oh. There you go.
Okay. Yes, there are on Postpartum Support International, there are miscarriage specific support groups. And then also some of the like therapy practices and things like that will have specific to pregnancy loss, miscarriage. Postpartum Support International also has LGBTQ group, a fathers group, let's see, they have a group for Black moms, they have a group for Hispanic patients, they have all sorts of different kind of groups. So they have a group for military members. So, if you don't kind of fall into, just sort of a straightforward pregnancy support group, then definitely check them out.
Excellent information. If you want to write down this email, the email in the chat, I believe they're asking you for a handout to be emailed to them. So
do you know, will this box go away like immediately when this is closed, or can I leave it open?
I think that it does go away once we close, but I can write down, I can send you the information.
Okay.
So, all right. Well, if nobody else has any more questions tonight, we're going to go ahead and log out. So thanks again for joining and doing this today, Mandy. It was a pleasure.
Yeah, no, thank you. Thank you so much. And if anybody has any follow-up questions or anything, then, you can shoot me an email. I can put that out too, but it's Dahlia Center at dahliaperinatal.com, or check out the website too if there's information there. So
perfect. Do you want to go ahead and just put that information really quick in the chat so participants can see it?
Oh, sure.
Okay.
Website, and that's the email.
Perfect. All right. Well, thank you guys so much for being here tonight. And on behalf of NAMI, I hope that everybody has a great night. And thanks again, Mandy.
Yeah, thanks. Everybody have a good night.
You too.